Thank you. You already know my disclosures, and we had an incident yesterday here, you know that. And I had to rush and try to find an AED. I tell you what happened. This was a mid-aged man that collapsed at the poolside outside the conference area. This was a stage, so this is not real, so relax. So I had a challenge to make people feel urgency, to make it as realistic as possible. But on one side, I said, no, this is just, it's not for real. So I had to do that. So this was happened. I clocked everything. 1:10, this is European. You can read European time also, that you see it 10 and a half minutes past 1. I saw the man falling down, and I judged that he had a cardiac arrest. He didn't respond, he didn't breathe, so it took me 45 seconds. And then I start to rush to find an AED. I rushed in here, I was a little stressed, and I couldn't see an AED, and who should I ask? Okay, I know these guys, they probably know, they have been here before, so I met Anita, and there was a sales rep, and I got them excited, and we ran to Tim Cox, and they didn't know anything about AED. They looked at me as I came from the moon, and then the rep said, go to the reception. That was good. So I ran to the reception, and there they had one in the back office. And I had really said, this is for, I must see it, but it's not for real. So they bought it. So I took a picture, clocked when I had the, so to say, the AED in my hand, and then I ran back and I clocked it. Knee beside the patient, AED electrodes in place, 6 minutes, 9 seconds. Okay, 6 minutes, 9 seconds. That's not bad, you think, but survival rate of out-hospital cardiac arrest decreased with 10% for every minute without CPR. So now we are talking about 60%. We have reduced the chance for survival with 60%. And you might say, yeah, but we have a lot of AEDs, and this is from the Swedish Society. I think it's global about the same. But over the 10 years, you see practically a flat curve, and it is survival rate, and the number until defibrillation can occur is the same. And AEDs, I mean, they are many times locked in because it's not office time you get a cardiac arrest. So this is obviously not the way to go. So I did wrong. I know, but I think many people would have rushed after an AED. I know how the guidelines is, and the guideline is check if the patients breathe or respond. If not, start to call 911 and then start to do chest compressions. Then you can have the chest compressions within 1 or 1.5 minutes. And the next one that comes to the scene, say, run after an AED and come back as soon as possible. That's the way to do it. So, every second counts, and we must recruit bystanders, people on the street, to be the first part of this care chain if we want to improve the results. And how do we get bystanders to improve? Because this is a giant problem globally. Cardiac arrest outside hospital counts for 4 million people annually. And most of the cardiac arrest is outside the hospital. It's even young. They must not have coronary disease. It can be young people, football player. And there is a challenge because early CPR is crucial, and bystander can feel fear of doing something wrong, and that must be taken away. And we also can improve the quality of CPR because the guidelines is to compress 5 to 6 centimeter in depth. If you are in that ballpark, that fits most of humans. And to do that, you need to be aware of this problem, and you need to train. And the training of CPR is limited. So this is what you can say about training. I think the left is how it is today. You have a training course every second year, and you see in this trial how you lost your competence. The way to do it seems to be low dose, high frequency training. But to do low dose, high frequency training, you need to offer the market something, Nabil, easy to use. So this is the solution that is simple to use. It's a CPR that it's an accelerator, and it measures step, and you can use it both in a real situation or as a training connected to the app. The app tracks your results. You can get instruction. What did you do wrong by a built-in AI coach? You can train it every Friday on afternoon in the office, and say the one who loses pays the beer, for example. You can do fun about training, and also you cannot buy a mannequin. A mannequin, you cannot have that at home, but you can have a compression pad, and with this you can do training, and this device has an indicator that reminds you when you have to perform rescue breath. The guidelines say after 30 compression, do 2 rescue breaths. But the most important is that you keep depth, and you will get a visual feedback when you do it. If you do green, you are correct depth, white too shallow, red too deep, and the compression must be around 110 according to the guidelines. So it's a sound and a flash that gives you the instruction. And it's also an instruction where to put the hands and where to place the device. And this is the app. You can see how was my pace. Oh, that's in the green space, that's good. The depth, I did some white, too shallow, and release. You have to release. Some red, I didn't release good enough, so on and so on. You can have the game on or the practice mode. And as I said, you can challenge. You can get a score. That is an algorithm that we have developed depending on these parameters I mentioned. And also then it's not a rocket science, but it's an AI instruction built on the outcome. And they say, do that and do that better, and not so, and see, and so on. That's what it is. And we have studies, and on lay persons, I take the yellow, small studies done by bachelors, but all say the same results. Accuracy increased for laypersons from 46 to 82%. Confidence level to do something increased with 73%. More willing to act increased with 53%. Even professionals, you think they can do it, they improved from 57 to 85%. Firefighters from 36 to 90%, etc., etc. And this is another survey of 364 participants. And they had to rate the device according to how it performed and if it facilitated and improved the training process. On a 9 graded score, the average was 7.7 to 8.3. So you don't need to have these wallets anymore. You have everything in your phone. So throw away that wallet. There are some dollars in it. So instead, when you go out and then you have this.
Are you performing CPR?
So I can see here, green. I do red. Oh, I'm going to breathe now. So, oh, well, that is what it is.
Thank you. I can't think of a better way to wrap up the innovation session. So, questions for Thomas?
I have a question.
Yeah.
How did you train? What parameters did you use to train this device to be adequate? Did you use end-tidal CO2 compression? How did you train your AI to get these?
Okay. I founded this company because I'm so bad on software. So I had to pass that question to my smart technicians. I cannot give you the detail. I haven't that knowledge about these things.
So when we do CPR in real time, my longest CPR that revived with only a little bump in creatinine was a 92-year-old guy who had a double balloon endoscopy, and upon the balloon expanding in his proximal duodenum, he went asystolic from 40 to 0. Usually, if I get somebody at 20 heart rate and I give them glycopyrrolate, I'm not an atropine girl, they will not go to asystole. The goal of any anesthesiologist is not to go to asystole. If you go to asystole, you've lost control. Even 20 beats, it'll be a slow return, but I will get the patient back. So with that patient, the best thing that happened was our CPR was amazing. After 22 minutes, they had done 6 EPIs, 6 cardiac shocks. And at that time, cardiac calcium chloride was out of the ACLS protocol. It still is. So when they were going to call it off, and nothing was working, we tried it. We just given 2 bicarbs, and then this was at Banner University, and they were going to call the code. And I had 2 calcium chloride. I'm a calcium chloride lover. It's a great inotrope. So they had just given bicarb. We gave calcium chloride. The next shock brought the patient back. But the goal was that CPR was amazing. We were doing it without waiting on Lucas, which most of the time distracts people and people die. Human CPR, if done well with end-tidal CO2 and great pulse pressure, is the only way. You can do CPR with breath for 2 hours and keep a patient alive. So that's the most important part. So how you train it to make this compression something that I can rely on would be it. Because the best way is when I see it now, I have great respect for CPR. Because a good CPR is the only way you can save a life. And people don't need to lose their focus on CPR, airway CPR, but of course you want the AED. I think the next thing on this is to make AED, which yours was confusing yesterday. I didn't know what you were looking for because a little bit of a gap, but I knew you were trying to tell me it was training. But I think we could have done it faster, but I think those AEDs need to be a little bit closer and maybe now pocket size. But CPR is the only way to save lives. Good CPR with end-tidal CO2.
I couldn't have said it better myself. Thank you, Anita.
But I still want to know how you got it.
The question is, what percent do you think of survival related just for the quality? I mean, the last paper in New England Journal of Medicine is true. Outpatient cardiac arrest survival less than 10%, in hospital less than 25%. Take them 12 minutes to find an access and so forth. So what percent would be related, do you think, of the survival?
In hospital, and correct me if you have other numbers, but roughly about 30% you can survive. But this is another group. It's not a young football player and so on. So I think that the cohort in the society is better than in the hospital. So I think that 30% it could be better than in hospital due to the other cohort we will treat.